You have just tuned into InnoStation, where the latest and hottest topics are always on air. I'm your host, Cami, and each episode we serve up heat with fun chats, fire insights, and special guest appearances with some surprises along the way. Now, World Health Day comes along every year on the 7th of April, and this year it launches a year long campaign that focuses on healthy beginnings and hopeful futures. We focus on maternal and newborn health and urging governments and the health community alike to intensify efforts to end preventable maternal and newborn deaths. And this is definitely a very important conversation that we want to have. And so we've invited the lovely Dr. Joy Saville to give us some insights into these focus points and the state of healthcare for women and children in South Africa at present. Dr. Joy, welcome to InnoStation.
Thank you so much, Cami. It's such a pleasure and an honor to be here today.
Of course, I'm so excited to have you. You always have such great energy.
Oh, thank you.
To kick off this episode, let's get to know a little bit about you. Tell us who Dr. Joy is and what fuels your inner fire.
Okay, perfect. I love this question so much. I think I've had so much time to reflect on it. The last year has been a bit of a whirlwind for me, and so it really made me question my identity and where I'm putting my identity in. And after a series of reflection and introspection, I can really say that the thing that now defines me is it being a child of God first. This is definitely where I get my childlike optimism, my the thought of that nothing is impossible. I can do whatever it is that I want to do because I am the daughter of a king.
Yes.
So there's a certain authority that comes with that, but there's also a humility that comes with that. Outside of, there's no outside of my faith. But outside of that, I am also a wife to a Zambian-born Filipino. We've been married for 14 years now. He's an artist. His name is Jojo. This is his artwork behind me. I'm also a mom to an incredible 10-year-old daughter. Gabriella, she is someone to look out for. I'm pretty sure she's going to take the world by storm one day. She's a dancer and an actress, and also a budding artist like her dad. I love children. I love animals. I love plants. I think this is where I get to be my quirky, childlike self. All of my plants have their own names. I have 2 dogs and a cat. What else about me? I love my community. So I have a very close-knit church community, a very diverse bunch of people that belong to our church from all over the world, and then from all walks of life here in South Africa. We're also blessed to live in a country like South Africa where there's diversity in race and culture and class, and I get to experience all of that. And if we zoom out a little bit, in terms of my community involvement here in the Fourways area, loved working with underserved communities in and around Fourways and in the greater Gauteng. And one day I hope, like I said, big dreams, but I really do hope and pray that I'll have the opportunity to go back to Cape Town, not on a permanent basis, but I grew up in an area called Mitchell's Plain. It's a colored township in Cape Town. And I would love to serve as an encouragement to people like me who grew up not thinking that we could dream big. So I would love them to know that you can. Your dreams are valid. You can dream big. There's nothing that's impossible.
Oh my goodness, Dr. Joy, your life sounds so full and so beautiful. And I love that. And I know that when you wanted to go back in Cape Town and everything, it definitely is possible. You have a very inspiring story. And even your career path has been very inspiring. I mean, you started off studying natural medicine, and then you later then went into Western medicine. And that was with the hopes of sort of going into specializing in pediatrics, right? Can you walk us through that journey? Like, what first prompted you to want to study natural medicine? And then what also led to you sort of sliding into Western?
Yeah, definitely. My dream was always to be a doctor. I think it was one of my earliest childhood memories was I'm going to be a doctor,
Mm,
and I'm going to be a pediatrician. Um, but along the way, that dream got derailed. I volunteered at Red Cross Children's Hospital in Mowbray, Cape Town, as a teenager,
yeah,
a very, depressed and moody teen, as most of us are at that age. And during that time, I remember coming home devastated, like just completely shattered that these beautiful children were suffering so much. They were just, they were either terminally ill or they were maimed in some way.
yeah,
One particular example of this was in the burns unit at Red Cross Hospital. There was this infant. He was so joyful. It was as if, he had no sense of awareness of what was going on around him. He
mm,
laughed and he played. But this little boy, you could smell the paraffin as you walked into the room.
mm,
And at under 1 years of age, he was already a double amputee, arm off, leg off. And it was in that moment that I thought, I'm not strong enough to do this.
yeah,
Um, and so I had no life plan after that. I went to UCT for a year, not really knowing what I wanted to do. My heart's still, in some ways, bleeding to be a doctor.
mm,
But I really wanted to escape the trauma that came with being in hospital. It was during that time, that first year of UCT, that I found out about a program called natural medicine.
mm,
And natural medicine allowed you to become a doctor, but you don't need to work in the public sector. And so I was like, okay, this is great. Like, I get to experience the best of both worlds. I get
yeah,
this title doctor, but I don't have to deal with the trauma. So it's a 5-year double bachelor's program that was offered at the University of the Western Cape. And I had no formal exposure to natural medicine prior to this. I mean, like I said, I came from a colored township. We were a low income family. There was no money. I was a recipient at Red Cross Hospital myself.
mm,
There was no money for things like homeopathy and, traditional Chinese medicine.
yeah,
But indirectly, I had been a recipient of the healing powers of nature. So, like I said, I had seen the wards of Red Cross one too many times. I had been admitted a couple of times. I had, acute gastroenteritis. I had meningitis. One of the things that I had more recurrently, I had a hole in my ear. And many people are born with it. It's just like a little hole over here.
oh yes,
Yes,
yeah,
have you seen
mm,
that before? Yeah, it's
yes,
called a preauricular sinus, and typically it's not problematic at all. Obviously, it became problematic for me. Mine became
mm,
infected, and I would get these recurrent abscesses that would develop, and then it would burst, and then it would develop, and it would burst. And so the ENTs at the time thought that it would be best to operate, but they had to clear the infection. I had received countless antibiotics and
mm,
nothing was working. I remember like being held down in hospital, and I don't know if they gave me an injection in my head. It's certain whatever it was really, really painful. But even that didn't work. And after going on holiday with my family to George and spending a week in the ocean, just like swimming and having fun,
yeah,
this abscess healed, so it was salt water, the sea water that had resulted in the healing of this abscess long enough for them to actually operate it because they needed intact skin and they couldn't operate over this infection.
yeah,
And so yeah, so indirectly I had this natural type experience. Um, but when I was studying natural medicine, I really fell in love with it. I loved the philosophy of natural medicine. There's so many modalities and therapies available. Big emphasis on lifestyle.
mm,
But my heart still longed for Western medicine. It was just like this desire that never left me. I would
yeah,
dream about it. I would pray about it. I would be like, Lord, like, is this from you? Is this like, am I coveting like something that I'm not supposed to have?
yeah,
Um, but in 2013, I had seen a 8-year-old boy. He had a condition called pulmonary hypertension. This is a condition to which there's no cure. And his parents were looking for They were looking for cure. They're looking for an
Mm.
alternative approach with the hopes of finding a cure for him. After about a month of seeing him, and I saw him quite regularly, we did something called cupping therapy. We made adjustments to his lifestyle. We had seen big improvements in his quality of life.
Yeah.
He went from being couch bound, on oxygen, to riding a scooter, driving a car for the first time at 8, playing soccer. And so we were really, really hopeful. But he had a short stay in hospital. He had, developed an upper respiratory tract infection, had an
Mm.
overnight stay in hospital. They had run all the tests. The tests came back beautiful. The first time in a year that he was getting, normal test results. Um, and a few days later, he woke up around 4, 5 in the morning, and he told his mom, "I'm going to die now."
Yeah.
And he took his last breath, and he died. And this completely devastated me. It sent me spiraling into this deep depression. But what it also did was it set off this cascade of parents with terminally ill kids coming to me looking for an alternative.
Mm.
Um, After a few years, I didn't for a while I didn't practice. I was too devastated to go back into practice. But after a few years, with much prayer, I had realized that I couldn't run away from something that I was ordained to do. I
Yeah.
was ordained to become a medical doctor. In addition to my natural medicine degrees, I'd realized that I was not in control of life and death.
Mm.
I am a vessel for healing, but the healing doesn't come from me, it comes from God. Um, yeah, and that I I really needed the experience and the education and training that you receive when you are a medical doctor, because I was out of my depth with some of these conditions. I had never
Yeah.
heard of some of them up and until parents would come and speak to me about it. So I really needed that extra training. And so that was the start of, my journey into reapplying to study medicine. In 2016, I'd applied to study at this. They had something called a graduate entry medical program. So
Mm.
that means that if you are a former graduate, you can enter into your third year of medicine.
Yeah.
So instead of doing medicine over 6 years, you do it over 4 years. Um, and obviously that was very appealing to me. And so I applied for this course. I did it's called a WAC test, a with additional placement test.
Yeah.
At the time, my brain was not braining. I had a 2-year-old daughter. Porridge brain was hitting me hard. But again, by God's grace, I passed that exam. It was also during that time that my husband was going through a retrenchment process. His salary had already been cut by 60%.
Yeah.
Um, and so we had no financial means of like covering this 70 plus thousand rand fees a year. But God was so good to us, and I received a full bursary for the 4 years of my studying. In 2017, I had received a scholarship that covered my living expenses. Um, yeah, my brain somehow got back to normal, and I passed all my exams very well.
Yeah.
Yeah, and so that was me and medicine. And like I said, the intention was to specialize in pediatrics. That's
Yeah.
definitely a big part of my heart, belongs to children. But last year, things didn't work out the way I thought that they would work out.
Mm.
Um, yeah, I was busy doing my diploma in child health last year, but I just could not find a position in peds. Um, However, the time that I had off, with unemployment,
Yeah.
it also made me realize that, I've been an absent mother for like 7 years by that time, and I really wanted to be present for my daughter and for my husband. And so, I prayed about it, and God said, well, you don't have to specialize to serve children.
Mm.
Um, you can be in general practice and serve kids.
Yeah.
And so that's where I'm at right now.
And speaking of where you are at right now, right? You are currently working with MedeScreen as well. Can you give us a little bit of background into sort of the organization and what the intention is behind it?
Okay. So yeah, so MedeScreen is a fantastic organization. And their heart is for, community development. But essentially they are pioneering medical technology company.
Mm-hmm.
And the dream is to create accessible and affordable healthcare for South Africans whilst serving the unemployed medical doctors.
Yeah.
Just on the side note, last year, so it was my first, so it was, yeah, it was post community service. There were 800 unemployed medical doctors in the country at the time.
Wow.
This year, that number has almost doubled.
Yeah. And
Actually,
you
it has more than doubled. It's not almost doubled, it has more than doubled. And so MedeScreen, yeah, the aim of MedeScreen is to do in twofold: provide accessible and affordable healthcare, serve unemployed doctors. With the accessible and affordable healthcare, they've developed this backpack that screens for 10 of the most common medical conditions.
mm,
The information is then processed through AI and it generates a electronic report that gets sent directly to the patient's device.
yeah.
It has something like 110 data points that we can then use to, make further decisions, see what the need is in that community. Alongside the backpack, when it comes to the unemployed medical doctors, MedeScreen really wants to provide mentorship, business acumen training so that because we don't get any of that, at med school. There's no business training
Mm,
at med school. And so, in order for us to run successful practices, we really do that. That's also the financial literacy part as well. So
yeah.
MedeScreen has really like tailored this complete package for us as post-community service doctors to have a better chance of having a successful practice, and
Yeah.
then simultaneously, providing better access. If it's someone that is from Limpopo, there's no need for you to be in Gauteng. You open up your practice in Limpopo.
Yeah.
It creates better access of healthcare for the greater South Africa.
Yeah, and I love that because you are right. The case of like unemployed doctors really has
Yeah.
become quite intense because you see, I've seen a lot of conversations online with just people, a lot of doctors coming out and saying like they're unemployed, and a lot of like us that aren't doctors are like, "What do you mean? What do you mean?
Absolutely.
I thought we had a shortage and there are
Absolutely.
doctors with
Mhm.
no jobs." But I
Yeah.
like the concept of MediScreen sort of empowering unemployed doctors to be able to run their own practices and also empowering access, right? And those doctors can then go into underserved communities and start practices there and serve those communities. I think that's a really great model. And another our topic that we want to go into is sort of things that we've seen online, much like the
Yeah.
topic of unemployed doctors. But
Yeah.
we've seen a lot of conversation around the suitability of medicine in general for women, right? And this discussion often focuses on sort of women's symptoms not being understood or often being overlooked, things like medical misogyny that female patients, nurses, and doctors
Yeah.
sometimes face, and also just the state of medical research and how little of it is dedicated to sort of women's health. And then I imagine by extension that also affects children's health as well, right? So, would you say that medicine in South Africa is in a similar state to what we've been seeing in the conversations happening internationally?
Yeah, I do. I do. Look, I mean, medicine is universal.
Mm-hmm.
And so the way in which we practice here, yes, of course, we've got our unique epidemiology in South Africa, but we still use global standards. And so, yeah, in terms of, medical misogyny, in terms of research of the way in which women present, do we present in the same way as men present? The current model that is currently being taught to us as med students and medical doctors, you know, is this based on male patients? Is this based on female patients? A
Yeah.
lot of it has been based on men and male presentation. Also, you know, I was reading up about something about, you know, just like treatment that is specific for women. We don't
Yeah.
have, you know, we don't have treatment specific to us, and so yeah, in that way, there are many similarities between the way in which things are run in the States and the way in which things are run here in South Africa. I think also like just like in terms of like just to make it practical, like
Hmm.
some big examples, like something like menopause, you know,
Yeah.
it's something that every woman, it's inevitable. It's an inevitable phenomenon for every woman. We are going to go through menopause, and yet, like, it is a subject that we know so little about as
Yeah.
medical doctors. In terms of our training, we don't get sufficient training on it. You know, the extent of it is you're not producing eggs, your estrogen is dropping, cessation of your period for a year, the end, the end. And coming into private practice and seeing just like the diverse impact that menopause has on
Hmm.
females and not knowing, you know, personally, like had I not done my own research, I don't think I would have known that a lot of presentation that women between the age of 35 to 50 are coming with it, it's actually like menopause.
Hmm.
So women are often misdiagnosed. They are often given, you know, cocktails of medication to treat, you know, this array of symptoms that they come with when there is, you know, suffering is not menopause is inevitable, suffering is not. Um,
Yeah.
and so yeah, just something like that, something as simple as menopause is something that is often neglected in our medical spaces. The other thing would be like analgesia for women. You know, if we go for an intrauterine device, you know, for something like the Mirena, we're not really, we don't get any analgesia, or we don't receive any anesthetic for that.
Mm.
You know, we get very basic analgesia. But if you had a lesion on your skin, you're gonna get anesthetized. You know, you're gonna get some
Yeah.
local anesthetic. You don't want to feel that. Yet someone is putting a device into your uterus, and you're not getting anesthetic. And so there is this disparity between the way in which men are treated versus the way in which women are treated. And I think that's a global thing. That's not something that's unique to South Africa. But we
Yeah.
do have our own unique discrepancies. Access to medicine in general is a huge problem in the South African context. But again, like when you look at things like reproductive and maternal health care, especially if you come from a rural community,
Yeah.
you have a lack of access to those things. Other things like, you know, gender norms. So women are often at higher risk of the transmission of HIV
Mm.
because a man gets to say that he wants to or doesn't want to use a condom. Um,
Yeah.
yeah, so yeah, there are all of those disparities that exist. Then another big one is gender-based violence. This is
Yeah.
like a pandemic in South Africa. And even if you have not been a direct victim of GBV, like as women, we still walk around with that kind of stress and fear every single day that we might be the next statistic. Um,
Yeah.
and for those that are unfortunately statistics, there's no specialized mental health care services
Yeah.
available in our hospitals to deal with that kind of stress and that kind of trauma that is caused. So yeah, so unfortunately, we do have a long way to go to bridge this gap. I know
Mm.
that as a doctor, I know that the number of female doctors are increasing in South Africa. That's great. It's still more male
Okay.
dominated, but I do think that there is an effort to increase the number of female doctors. But there's a long way. We have a long way to go. before we have that kind of equity in medicine.
Yeah. And just speaking on sort of different presentation in men and women, what are and also with the issue of women's symptoms often being overlooked, can you tell us what some of the most common overlooked symptoms are during pregnancy, especially, and just things that we might not necessarily regard or know as danger signs until it's actually now a big problem?
Yeah, yeah. In terms of overlooked symptoms, yeah, I would definitely want to start this conversation by saying that um, during pregnancy, for all women, whether this is your first baby or your fifth baby, like one of the most important things that you can do for yourself, for your health, and for the health of your little one is to
Mm,
get booked early into some sort of antenatal care. Um, because they are, some of these danger signs that I will speak of, sometimes they can present as like normal pregnancy symptoms, and you would need a critical eye to establish whether or not this is something that needs further investigation, or if this is just pregnancy. Okay,
yeah,
so please, ladies, even if you're an experienced mom and you have done this so many times, get booked, do your
yeah,
ANC, okay, bookings. Just on that ANC booking, the other thing that I think is also really important to mention is youth services. So
mm-hmm,
for our teen mommies, and this is, we often see late booking with our teen moms because of the stigma that is attached to pregnancy in the teen years, or fear
yeah,
that their parents are going to find out, or fear that it's not going to be well received in that kind of clinic setting. And I do think there's a call to healthcare workers is to be more youth sensitive, to provide
mm,
a space that is safe for our youth to enter into, free of any sort of judgment or discrimination. But our teens are also, they are high risk group when it comes to pregnancy. And so they also need to, yeah, for their life and for the life of that little baby that's growing inside of them, they also need to book early. But as healthcare workers, we also need to receive them more sensitively. So
yeah,
that being said, in terms of danger signs, so what I'll do is I'm just going to look at some of the common causes of maternal death in South Africa, and then we'll look at like,
yes,
some danger signs there. So the first big cause of maternal death is actually non-related to pregnancy. It's infections not related to pregnancy. So things like
okay,
HIV, TB, pneumonias, those are the three big ones. Um, and again, like something like HIV, pregnant women are at higher risk of transmitting or of becoming infected with HIV during the time of pregnancy. We
okay,
now have, we've changed things up a bit where we actually do test at every antenatal visit. Okay,
mm,
so this is again just highlighting the importance of booking for antenatal care so that you can get tested at every visit. We do a verbal screen for TB. So the symptoms would be, a cough more than 2 weeks, loss of appetite, loss of weight. As a pregnant woman, we don't want to see a loss of weight. Um, and then night
mm-hmm,
sweats, and then any fever, So if you're feeling hot, and not only just internal heat, you turn on your head and you're feeling hot, this warrants further investigation. Okay, this warrants you going in and getting checked out. Um, so that's the infections not related to pregnancy. Then medical and surgical conditions. Okay, that's another big one, another big cause.
mm,
And the biggest like subcategory cardiovascular heart disease. So here, this is why I'm saying like we can often miss this if you are not coming in.
yeah,
Shortness of breath, which is the pregnancy symptom. The bigger your tummy grows, the less space for your lungs to expand, so you can become
Yeah.
short of breath. Fatigue, another one that can just be mistaken as a pregnancy symptom, and then swelling of the legs and the ankles. Okay, so if you have any of those, it's important for us to discriminate whether this is something to do with your heart or is this just features of like a later pregnancy. Okay,
Yeah.
so that's the cardiovascular. The other one is hypertensive diseases in pregnancy. And so the hypertensive diseases is also a big one, a big cause of premature deliveries,
Okay.
and of your either your neonatal deaths, your early neonatal deaths, or your stillborns. Okay.
Mm.
And with the hypertensive disorders, the danger signs over there would be a severe headache, blurry vision, shortness of breath, pain in the top part of the tummy, okay,
Mm.
and then again swelling, okay, and oftentimes we see swelling even in the face, okay. A later symptom of or later red flag of uncontrolled blood pressure in pregnancy is something called eclampsia, where the woman starts to fit.
Yeah.
Okay, but obviously we don't want it to get to that point, because that's quite a late, and that's
Hmm.
that's where things become quite dangerous. Like again, high blood pressure in pregnancy, if managed correctly, mom and baby can do well. But if it's not managed, if it's missed, if you are 8 months pregnant and now only coming in for antenatal care and your blood pressure is through the roof, it poses a big risk for both you and your baby. Okay, so there's the hypertensive disorders. Another one is obstetric hemorrhages. Okay, so this would include any sort of vaginal bleeding from 26 weeks onwards
Hmm.
and up until the postpartum period, typically the first 24 hours after giving birth, but it can be up
Hmm.
until 6 weeks. Okay, so any sort of bleeding in pregnancy is a red flag. All right.
Yeah.
The obstetric hemorrhages, like I said, after 26 weeks, but then earlier on in pregnancy, if you are bleeding, even if it is, not a lot of blood, if it's like spots of blood, but you're
Yeah.
having severe lower abdominal cramps, okay, we want to rule out ectopic pregnancies. We want to rule out miscarriages. Okay.
Hmm.
Yeah, so those are some of the red flags with looking at just like the common, the top causes of maternal deaths in South Africa.
Yeah. I think that was like a lot of information,
There's a
but it
lot.
was a lot of
I know.
important. But it was a lot of important information, right? Because some of these
Yeah.
symptoms I've heard like people that were pregnant be like, yeah, my feet are swelling. I'm just going to put them up. You know, a lot of these things aren't regarded as red flags until, like I said, it's like a big issue. And so I think it
Yeah.
is important to sort of have just these general basics of like what is common. And like you mentioned, like getting into your antenatal care early on so that these things are able to be spotted at every turn, Sure. Now in South
Yeah.
Africa, it is, but in South Africa, in particular, the probability of a child dying before reaching their fifth birthday is approximately 35 per 1,000 live births. What are some of the common reasons behind this issue? And is there anything that you would recommend that we can do at a parental level and then also maybe at a sort of governmental or like public health level that can help lessen this figure? Because I think 35 and 1,000 is a lot.
It is a lot. It is a lot, and it's really, really tragic. I think the tragedy of the statistic is that a lot of these deaths are preventable. So that's
Yeah,
heartbreaking that it can actually be prevented. Um, but yeah, let's get into some of the causes first. Okay, so the
yeah,
big one there would be death in the neonatal period. Okay, so that's the first 28 days of life. And a lot of these
mm-hmm,
maternal conditions that we discussed, they are risk factors, or they predispose our little ones of being born prematurely, um,
Yeah.
being born with, birth asphyxia, so a lack of oxygen to the brain. Um, yeah, which then makes survival less likely. Okay, so again,
Mm.
just going back to the booking of antenatal care and the importance thereof, yeah, the early booking is essential. Okay. Um, then there are your top three, very preventable causes: diarrheal disease, okay, pneumonia, and then severe acute malnutrition. Okay, so this
Mhm.
accounts for the other 75%, or not exactly 75%, but this accounts for a large majority of deaths in our children under 5 years of age. There is a report that's available. It's called the Fourth Triennial Report of the Committee of Morbidity and Mortality in Children Under 5 Years, okay, or COMIC. I'm just going to say COMIC for short. And this report
Okay.
was published in 2020, and it reviews 2017 to 2020 stats of childhood mortality. And
Mhm.
one of the big behind childhood death in the under five population, and this was across the board with parents, with healthcare workers in the accidents and emergency department, as well as in the wards itself, was not recognizing danger signs. Okay,
Yeah.
so again, with when it comes to parents, just the knowledge of what are these danger signs, and if my child has a danger sign, what does that mean? Like, what am I supposed to do? And typically, any danger signs warrants immediate um, going to the hospital or to the clinic immediately. Okay.
Yeah.
In our Road to Health card booklets that moms receive for their babies at birth, there is a page that lists a lot of these danger signs. Okay. I just want to go through it
Mhm.
with you. All right. And it has pictures as well, so that there can be some understanding. And then we'll talk about some of the shortcomings of this. All right.
Okay.
So if the child is coughing and breathing fast, okay, and it says more than 50 breaths per minute. Child under 2 that has a fever and is not feeding. Child is vomiting everything. Child has diarrhea, sunken eyes, and sunken fontanelle. Child is shaking, convulsions. Child has danger signs of malnutrition, swollen ankles and feet. Child is not moving and does not wake up, and child is unable to breastfeed. Okay, so it is
Yeah.
important for parents to have knowledge of this. But one of the big shortfalls of this is that it's only provided in English. Okay, and living in a country like South Africa, we definitely need to offer this information in more than one language.
Yeah.
The other thing is that there's still, as much as they've tried to keep it simple, there's still medical terminology, a fontanelle, I don't
Yeah.
know
Yes.
how many lay people know what a fontanelle is. And so we really do need to look at working on our language so that it can actually address the educational needs of the people that we are trying to educate.
Yeah.
Um, the other big issue here is some of these signs are late signs, like lethargy. A child is not moving and does
Okay.
not wake up. That is a late sign. We do not want a lethargic child coming to hospital. The prognosis there is not great. And so that was another thing that was mentioned in comic, was that patients present late you
Mhm.
know um and I've worked in the pediatric department, and I've seen it is a nightmare, especially with your diarrheal disease. Kids are in shock, they are so dehydrated, we cannot find a vein anywhere, we resource limited, we try to put lines into the bone directly. Sometimes it works, sometimes it doesn't work. But it really is a nightmare to work with a shocked baby. And so,
Yeah.
again, early presentation. Um, early presentation and education. So we should be, and again, this is, again, when we talk about resources, human resources, you know, and I know a lot of hospitals and a lot of clinics, they have health promoters, um, that provide education and training to, or provide, informative discussions around some of these conditions.
Mm-hmm.
I'm not sure how. I know in Gauteng, in the clinics that I was at, there was always a healthcare promoter, but going more rural, is this something that's available to people in the more rural areas? But yeah,
Right.
we should be educating our parents in their language, in a language that they understand, with simple, language, not medical terminology, on these danger signs.
Yeah.
Then, like I said, failure to recognize danger signs early, even in a hospital type setting. And again, I think it's another resource problem. The ratio of healthcare workers to patients it's disproportionate. There aren't
Yeah.
enough healthcare workers, and so this often results in, we should be reviewing. Child comes in dehydrated or shocked. We should be reviewing this child as frequently as we can. Okay, and there is guidelines as to the times that we want to review. Um, but oftentimes, again, as a for someone that came fresh out of the system, you are running around all night. You
Yeah.
are in theater delivering preemie babies. You are dripping. You are in the high care setting. Trying to tube little babies. And so the review process can often be delayed.
Mm-hmm.
And so this is, this failure of recognizing danger signs and acting on it soon enough. You can often you go back in, and the child is worse or more dehydrated than what they came in, maybe
Yeah.
because their drip moved. Their drip is not actually in the vein anymore, so they're just getting a whole lot of fluid in their arm. Um,
Yeah.
yeah, so that's some of the things that comic addresses. They also speak about, a lack of facilities like a high care facility or intensive care units in your higher level hospitals. And this is also a big reality for us. Sometimes we have kiddies that have very specialized needs, and they need these specialized services. But
Mm.
the high cares and the ICUs are full, you know.
Yeah.
Um, yeah, so a resource, there's a lot of resource constraints. I think the things
Yeah.
that we can change in the immediate period is providing education. Um, the other thing is when it comes to something like malnutrition, and malnutrition is also, it's often a risk factor that um, not only is a direct cause of childhood death, but it can also be an indirect cause. So malnourished children are they're more likely of getting infections.
Mm-hmm.
And there's this twofold thing with malnutrition. The one is, the malnutrition causing infection. The other side is the infection causing the malnutrition. Um,
Right.
but again, like kids are supposed to, up until 18 months, they're coming in quite regularly for their vaccinations. And then from 18 months to 5 years of age, they should be coming in every 6 months to receive vitamin A supplementation, to receive their deworming meds. And then this also provides an opportunity to check weight, to check
Mm-hmm.
height, to assess their milestones. And I think sometimes when a child is falling off their growth chart, okay, when there's a decrease or a plateau, this is when we should be acting already. We shouldn't be waiting until they're severely malnourished before acting. We should be employing our allied health services, our dietitians, our social workers to investigate, what is the type of food that this child is eating.
Yeah.
Is the mom on a grant? Is the child receiving a grant? This is the types of food that you can buy with that grant money that is going to nourish this child and give this child the nutrients that it needs so that they don't become malnourished. So I think those
Yeah.
are two very big areas that I don't think is going to have any sort of cost. Well, there will be. There's always a cost implication.
Mm-hmm.
But it is something that we can change in the immediate period. Um, the other things, the resource and the lack of resources, those are much bigger problems that at
Social
a much
media.
higher level than my own, they need to deal with and discuss how to remedy that.
Yeah. And I think an overarching message that I'm sort of picking up from this episode is that it's very important to go to the doctor's office and don't miss like your checkups, don't miss your appointments and stuff, right? Because I think, like you are saying, a lot of these things are preventable, but either because of a lack of resource and a lack of access to like a healthcare facility or whatever other reason, people are coming in late and then it's hard to sort of address the issue. And speaking of sort of
Mm,
things like access, right? There is the conversation then that we must have about like private healthcare versus public healthcare, right? And I think there still is this sort of villainization of the public healthcare sector and the quality of public healthcare as well, right? I mean, there's a lot of like
mm,
sentiments like, oh, you go into public healthcare, it's going to take forever. You might go in there and not come out. There's a lot of that
yeah,
going on. But you
yeah,
have worked in the public sector yourself, right? So I just want to get your perspective
yes.
on sort of public healthcare and sort of from a doctor's perspective, the state of public healthcare and how the conversations that go on are sort of maybe contributing to the issue of like people not showing up at the doctors, right? Because if you don't have access to a private facility, you do have access to public.
Firstly, I want to say that we never want to diminish someone's lived experience, okay? Because the experiences that you've had it's valid experiences, and also just to mention that a lot of these experiences are not unique to the public healthcare system, okay?
Yeah.
But the truth is that in the public system, healthcare is expensive. Now being in private, I can see the cost of healthcare. A simple chest X-ray. I mean, I was just inquiring for a patient of mine that's not on medical aid. An X-ray is more than 700 rand. A lot of these blood
Sure.
tests that we do in our practices, they can amount to thousands of rands.
Mm,
And so, a big benefit of being in the public sector is that it's either very low cost, okay, you are going to pay a literal fraction of what you would be charged in the private sector. Um, and then also just like accessibility, like just like in terms of certain surgeries, minor procedures that would be completely unaffordable if you had to do out of pocket payments in the private sector, is available to you in the public sector. Also,
yeah.
you have the benefit of, especially if you are at the academic hospital, you have the benefit
Mm,
of working with some of the best professors and doctors in the world. You get to consult
yeah.
with you know you, people with so much knowledge and insight. It's one of the it's like a perk and a not perk of being in the South African healthcare system as a medical practitioner is that you get exposed to so much because we are a middle income country.
Yeah.
But these professors, they have so much knowledge and insight. And again, that knowledge and insight, had it been privately, it would come at such a big cost. Um,
Mm-hmm.
and people that are recipients of public health care, they get to experience it at either free or low cost. Um,
Yeah.
that being said, yes, of course, waiting times are frustrating. That's one of the big shortfalls of being in the public sector is that you are going to have longer waiting times. It's not as convenient. It's this discrepancy of healthcare professionals and patients, or resources in terms of hospitals, the amount of hospitals that we have available, and the number of patients that we need to deal with. So
Yeah.
yeah, waiting times are often, it's long waiting hours. Um, And I know also sometimes if you face someone that is a bit grumpy, it's
Yeah.
inexcusable. But I also feel like, just like as someone that has just come out of the public sector, am I um, as someone that's come out of the public sector, like, give that doctor or that nurse the same amount of grace as what you would want to receive from them, because the likelihood is that they've been on their feet for
Mm.
more than 24 hours. They have not rested. They have not slept. They have barely eaten. They're just pumping themselves full of sugar just to get through. Um,
Yeah.
but at the same time, they could be the most passionate doctor about your health. They might just have a bit of a sour face in that moment. But yeah, there is. I mean, there's a lot of work that needs to be done um, to provide dignified service to our communities in the public healthcare sector.
Mhm.
But at the same time, like, I don't think that we must ever forget to downplay the expertise and the heart and the work that a lot of these doctors are putting in to provide services, often sacrificing their own time, their family life, their own health. That's a big one. So yeah, it is need to weigh things out a bit.
Yeah.
But there's a lot of benefit of being a recipient of public health care.
And I think that was a very balanced answer because yes, it does have its challenges, but like you said, you do have access to some of like the best doctors in the country, and
Absolutely.
yeah, that can go a very long way. But
Yeah.
yeah, I think this conversation has been very enlightening, and I think it will also open up more conversation, right, around the states of healthcare, especially with the focus of this year's World Health Day being around sort of maternity and sort of women's health and the impact that that then has on infants as well. Now, before I let you go, Dr. Joy,
Mm.
I would love to play a game with you. We have a game that we play here at InnoStation called Hot Takes. And how it works is I just ask you a series of rapid fire questions and you answer hot or not,
Okay.
depending on how you feel about the subject.
Okay. I can do this.
Also, hopefully the rain doesn't like mess with our connection too much.
I
But
know. I know.
but yes. So tell me, how do you feel about matching family outfits on Easter?
Not.
Not. Why not?
Ah, you know what? That's so much work that goes into like matching your outfits. I have no time for that life. And I think it's beautiful on other people. It's beautiful on other people, but
Yeah,
on me, I don't know. I'm just like too like low stress, low maintenance.
the admin of it
Yeah,
all.
exactly.
And how do you feel about animals in little sweaters?
Oh, the cutest. The cutest ever. I get cuteness aggression when I see animals in little sweaters. Yeah, I know there's people judging me right now. That's okay. It's okay to
I
judge
don't
me.
think so.
My doggies have sweaters. I have a dog that can't regulate his temperature. So when it's cold, I need to put like a little jacket on him. And then I have
Yeah,
another little doggy that I just adopted that he's so small. He's like a little newborn baby that's going to stay a newborn forever. I definitely want to dress him up.
it's so cute. I definitely
It
agree with
is.
you. How do you feel about tiny bonsai trees?
Tiny bonsai trees, they're cute. I love plants.
Yes.
Um, I don't own a bonsai yet because when I got into my plant life journey, I actually had brown fingers, not green fingers. I was killing things all the time. And I know bonsais are quite sensitive, and
Yeah.
so I haven't yet got myself a bonsai, but you have given me a fantastic idea for this weekend. I'm gonna go bonsai shopping for like a
Love
cute
that.
little.
Oh my goodness, love that. We'll follow your bonsai journey and see how it pans out. See if how
Please
green your fingers
do.
have become.
The green now, things are flourishing here. It's flowers and it's beautiful.
Lovely. That's good then. But how do you feel about building blanket forts with the kids?
Hot, yeah, hot. I think one of my core childhood memories is building blankets with my brother.
Mhm.
And definitely when my daughter was growing up, the things that we could do together that didn't cost any money because I was a broke student at
Yeah,
university. And so we loved building little forts and making little houses and having little picnics under the blankets. Yeah, such a fun thing.
it is. It's so cute. How do you feel about church potlucks?
Hot. Anything with food and
Yes.
and food and community, food and people. It's my
Always
thing.
fun,
Love
right?
it. Yeah, yeah.
And how do you feel about worship services with a full band and lights and all of that?
Yo, I'm for the vibes. I'm for the vibes. I'm low maintenance in some areas, but I love a good show. I love the
Right?
lights and the bands and the music and good vocals. It's actually something that my business partner and I we do it once a month. It's called First Fridays. I think they have it in Cape Town, Durban, and here in Johannesburg.
Hmm.
And so it's just amazing. We just
It's
love
just right.
the vibes is vibing. People are like just feeling the spirit. Yeah. Yeah, so definitely that's my thing.
Definitely hot. How do you feel about sleeping with pets in your bed?
Not not for me. I
Hmm.
love my babies. I'm a terrible sleeper. If I could sleep by myself, that would be my dream. That would be my dream. I'm just such a light sleeper. Any movement will disturb my sleep.
Yeah,
Knowing that there's a life next to me and a little life would disturb my sleep. Um, yeah, it's a not for me.
so not. How do you
Yeah.
feel about naming your plants like their pets?
Oh, no, I do that.
Do
That's
you
me.
really?
That's my quirk. I've got Mona Lisa. I've got Frida. I've got Medusa. I've got this. Yeah, all my plants have names. I've got Peace. Yeah. If I go through all of them, we'll be here all day.
Ever?
But I name everything. It's even fish. We've got like a lot of fish over there. There's a Moana in there.
Yeah.
Yeah,
No, I
I
love
name
that though. They
everything.
all have such iconic names, like a Medusa.
Exactly, exactly,
Love that.
exactly.
If
Yeah,
you're gonna do it,
Medusa's leaves look like snakeskin. So
okay.
hence the name
Hence
Medusa.
Medusa.
Yeah.
Okay. And how do you feel about Coco Melon?
Not, not. I'm so grateful that I did not have to experience the era of Coco Melon. I mean,
Yeah,
I'm sure it is a lifesaver for most parents with young children.
yeah,
Um, in my time, we were jamming to Clamber Club. That was our jam. But Coco Melon, I think maybe it's just because my child is older now. I'm
yeah.
sure if I
She's
had
grown out
another
of that.
baby, exactly. If I had a little one, I would totally Coco Melon because we all need our sanity. We all need a little bit of time just for us mommies.
Yes.
So no judgment to the moms that put on Coco Melon and let their kids jive to that.
Yeah.
But sure, I know that's trauma. That's
Was your daughter
PTSD.
during the baby shark era?
She was a baby shark, yeah.
Oh gosh,
She was
that was what a time.
she was a baby shark. But you know what? Actually, now that you say it, it's like a sweet memory. It's like a
It's sweet
fond
now,
memory.
but living it, I remember my baby cousin is also a baby shark girl, and
Yes,
oh my goodness, the whole day that's all you're hearing in your head. It's like,
all the
baby.
time. All of the time.
And Dr. Joy, how do you feel about kids picking their own outfits?
I love it.
Mm,
I love seeing the little personalities come through in the quirky little outfits that they wear. And I love that kids are just like so free of like what the world thinks about them. I think
Yes.
we focus so much on the opinions of others that we don't really express ourselves
Yeah.
truly. We're not really true to ourselves. But kids don't have that. They have no
Yeah.
inhibition. So I love when kids pick out their mismatched outfits, little tutus and gumboots and goggles. I think it's the cutest thing ever.
And it is such a vibe. You're like, maybe I need to get myself some gumboots and gum.
Absolutely, absolutely. And jump in some puddles. I
See,
mean, why are we not jumping in puddles like we used to? I'm sure
jumping
that's going to
puddles.
release.
And it is raining today, so definitely.
Exactly. I just need the gumboots. I need to go and, invest in a pair of good gumboots.
Exactly. But Dr. Joe, that brings us to the end of our game and, of course, the end of our episode. Thank you so much for joining us today and for sharing all of that insight. And hopefully, this episode is going to reach people that need to hear that information, especially all of like the sort of signs that you gave throughout the episode. I think those are very important for people to tune in on. Now, before I let you go, do you have any socials that you want to plug? Any um, resources and stuff like that that you would like for us to drop in the comments as well?
Yeah, absolutely. So we actually just launched our website. Yesterday was our
Okay.
launch day for our website. It is so beautiful. We are so
Congratulations.
grateful. Thank you very much. Yeah, we had an amazing teamwork on our website that really captured our heart. So
Hmm.
please do check that out. It's Doctors DRS Taz and Joy
Okay.
.co.za.
Okay.
Okay, so that is, and then on social, on LinkedIn, on Instagram, on Facebook, the same, Doctors Taz and Joy.
Okay.
That's our social media handles. So please go and
Awesome.
check us out, see what we are doing. Like we said, we have a heart for community. We need your support with our community developments, with our
Hmm.
outreach projects. Through MedeScreen, you can actually buy vouchers.
Yeah.
Yeah, so you can put that link down as well to the MedeScreen site,
Okay.
where people can sponsor a voucher, and then we go out and do wellness screenings and education on community members.
Perfect. We will link all of that in the description box for everybody at home to find. But thanks again for joining us today, Dr. Joy. And thank you at home for tuning in as well. See you in the next episode.